So what we've been talking about is just an introduction to hemoglobinopathies in general. So now let's talk about some actual hemoglobinopathies, okay? The most common symptomatic hemoglobinopathy. Now it talks about symptomatic, that means it's causing problems. Remember, there was over 1,100 variations of hemoglobin, okay? They're all considered hemoglobinopathies, but there's some that are common that don't cause any problems, okay? So that's the reason why we talk about sickle cell as the most common symptomatic hemoglobinopathy. There are some that are actually more common, okay? Prevalent in tropical Africa. All right, so something really weird, okay? So a lot of times you see, all right, so biology, okay? So I don't believe, I'm a biologist. I have a master's degree in biology. So I've done just about every biology class you can think of I've taken, but I'm not a believer in evolution, okay? I just don't. You've never convinced me, no class that I've ever taken or professor that I've ever had has convinced me that evolution is real, okay? It is a theory, all right? But I do believe in survival of the fittest, okay, which is a form of evolution, but I believe that no matter what. And you can see this happens every day, okay? So why would you think that people in Africa, especially tropical Africa, would be able to survive with hemoglobin S compared to people who don't have hemoglobin S? Okay. So you guys just finished talking about protozoans in micro, right? I took a protozoan test the other day. One of the protozoans, Plasmodium, which is malaria, okay? It is scientifically proven that people who have hemoglobin S are resistant to malaria. So therefore, what happens? Those people survive, and the people who don't have hemoglobin S end up being infected with malaria, and lots of them die. So that's the reason, one of the reasons why we see high numbers of African, okay? Now, I know that sounds strange, but African Americans, we're talking about people who live in America, who are black, okay? African descent, all right? A lot of times you'll just see black African, okay, on some of your textbooks and stuff. Those are talking about people who still live in Africa, okay? So people who live in like West Africa have a huge number of percentage of people who have sickle cell anemia. And the reason that they do is because they developed basically an immunity to malaria, because the malaria parasite doesn't eat the hemoglobin, that's hemoglobin S. And so therefore they survive, where people who are normal, they get malaria and die. And so it basically killed off a population of normal individuals, and so you have more sickle cell patients or people living in West Africa. Okay, so that's a little history or a little thing that's unique about hemoglobin S. Other than that, there's nothing good about it. Okay, as we go, and you guys will see that as we start talking about these hemoglobins. All right, Mediterranean places like Iraq, Iran, around the borders, Kuwait, those places, you can have some prevalence of hemoglobin S. Middle East. In the Middle East, we're talking about like Iraq, Iran, those places, Saudi Arabia, India, and Nepal. And then there's even some in a little bit in Southeast Asia that you might see some hemoglobin S. Taiwan, Cambodia, Laos, those kind of places, Vietnam, those kind of places as you go, okay? But then, of course, we have geographic migration. So you see places in North, Central, and South America that also have some prevalence of sickle cell, okay? African Americans. So African Americans, of course, this is a African American disorder that is more prone to them than it is Caucasian. Sickle cell disease is actually pretty low right now. And So how do you say this without being morbid? The reason the percentage is low is because they die. I mean, they just don't survive very long. A 50-year-old sickle cell patient is an old person, okay? And usually they don't make it till about 40. 35 or 40 is old for a person who has sickle cell. So of course your percentage is going to be a little bit lower, okay? And notice the carrier though, carriers, people who are heterozygous for it, the numbers are increased 8 to 10% as you go. So sickle cell anemia is one of the most common symptomatic of these hemoglobinopathies, okay? All right, questions about that, guys? All right, so what is hemoglobin S? So hemoglobin S is on the beta chain, so we still look at it as 2 alpha and 2 beta, no matter what. The only difference is we look at 2 alpha and 2 beta, okay? The difference is instead of it being beta A, it is beta S, okay? And when we put that S, it's usually got 2 S's. It'll be beta SS, letting you know that that individual is, both betas have an S gene, okay? Now sometimes you may, of course, this would be the sickle cell patient, okay? And then this one is your sickle cell trait. We're going to talk about it in just a little while, but go ahead and throw this out there for you, okay? And this is what they would look like here, and that's letting you know that you've got your 2 beta genes, but one of the betas is normal, and the other one is mutated to that sickle, or the S, hemoglobin S, okay? So, like we talked about before, we talked about, and listen to me, this is very, very important, okay? You need to memorize this and know this, okay? Glutamic acid is replaced with valine in the 6th position of the beta chain at the A3 helix. Okay? Glutamic acid is replaced by valine at the 6th position of the beta chain in the A3 helix. Okay? I promise you, you're going to see that somewhere on a board down the road. Okay? It's just one of those things. I had to learn it years ago because it was on boards. You know what I mean? It's just one of those things that's basic knowledge of hemoglobin S. All right? So, go ahead and learn that, and of course this is the new nomenclature that you guys should have known for your test today, your quiz today, okay? So, let's talk about nonpolar versus polar, okay? Because, all right, glutamic acid is polar, whereas valine is nonpolar. And this is exactly what causes our hemoglobinopathy, our problem with hemoglobin, okay? So, when we talk about polar and non-polar, and you guys, everybody had chemistry, or taking chemistry now, or in the middle of it, you may not have got this far if you're in chemistry now, okay? So, let's talk about a very common molecule that you guys are all familiar with, and that would be good old H2O, right? Water. We like water, right? Water is a polar molecule, okay? Oil is nonpolar, okay? Most oils are all non-polar, okay? So let me ask you, can we mix those two together? Not naturally. If we add some stuff to it, some other chemicals, we can get it to do it. But just in a natural state, they don't ever mix together, okay? So when you take a molecule that's supposed to be polar and you add something that's non-polar, it doesn't work properly, okay? All right? So what makes polar and non-polar? Okay? Polar, you have sharing of electrons, okay? But you have what we call unequal sharing. So in other words, you end up having a net charge on each molecule. So what happens is, in reality, we always draw water like this, but in reality, it's more like this. Okay? And the reason it's like that is because hydrogen has one little electron that it wants to share with oxygen. Oxygen has 6 electrons in its outer shell. How many does it want to have? 8. Every element in the world, with the exception of helium, wants 8 electrons in its outer shell. Okay? Helium wants to have 2 and does have 2. Hydrogen would like to have 2. Okay? So what happens is, when they form a bond, these 2 hydrogen molecules give oxygen a full 8 shell, and then it can share one of those with hydrogen to give hydrogen 2. Okay? Here's the problem. All right? Hydrogen has 1 proton in its nucleus, right? How many does oxygen have? Huh? Is it 6 or 8? I can't remember. Look it up on the thing.
For oxygen?
Yeah, it's oxygen 6. Okay. All right. So 6. Can't remember if it was 6 or 8. Right off the top of my head. So 6 of these protons in its nucleus. Okay. So y'all know that little gray magnet crap you can buy at Walmart to stick on stuff, and it just barely, sometimes it'll stick, sometimes it won't, you know, because it doesn't have that good of a magnetic field. And then you know the guy that works at the steel place that's got the electron magnet on his thing, okay? This is hydrogen, and this is oxygen, okay? Because oxygen has a stronger or larger nucleus of protons, it can pull those hydrogen atoms closer to its center. Does that make sense? So when you pull it closer to it, now they're not sharing electrons equally anymore. So now you end up with a charge on the ends of each atom. Does that make sense? Okay? That's what polar means. Okay? Anytime a molecule is polar, you see it as a polar molecule, it's this area. It's got charges on both ends. Okay? Because it has unequal sharing of those electrons. Okay? Whereas nonpolar, you have equal sharing. And I'm going to put electrons like that. Okay? That is a symbol for electrons. Little e with a negative symbol. Okay? So, essentially this, guys. It's like changing water to oil. Essentially, when you substitute that one amino acid. You take a polar amino acid, and it should have been a nonpolar, or a nonpolar, and it should have been a polar. That kind of thing. It's just reversed. So when you do that, that changes the properties of the protein. And so the protein doesn't act like it's supposed to. And that's what we get when we have hemoglobin S. Okay? So what does hemoglobin S do? All right? It changes the electrophoretic mobility of it. Okay? So we've already talked about electrophoresis. All right? It's going to travel a little bit further than like hemoglobin A does. It's a little smaller. And plus, it's got that charge difference. And so it is more negatively charged, so it is more attracted to that positive A node, okay, as it goes. So that's one of the things that's different, all right? It also affects solubility, okay? So you can look at oil and water, and they're not the same. They're both liquids, but they definitely have totally different properties, right? So this is what happens with hemoglobin S. When hemoglobin S is present in certain conditions, And one of the main conditions is when you have low oxygen, okay? Low oxygen is the key to people who have sickle cell anemia, okay? People who have normal oxygen levels, who are sickle cell anemic patients, so basically have hemoglobin S, they have normal red cells. Their cells are just as normal as they can be, okay? But as soon as the oxygen level drops, then chemical reactions start taking place. And one of the things is basically it becomes like a milkshake, okay? This is my best analogy, all right? So, normal hemoglobin is totally soluble. It's like water. It's thin like water. You have no problem, okay? Hemoglobin S is the same way until oxygen levels drop. Once oxygen levels drop, though, the hemoglobin turns into a milkshake, okay? It's still liquidy, but it is thick, okay? All right? So, when you see the word polymeration, what do you think about? You're like, I don't think about anything. Okay? Shape. I can go with that. What's the first part of that word? Polymer. What's a polymer? Plastic. Rubber. Those are all things. So essentially, a polymer is when you connect things together. Okay? And that's what happens. So when you see the word polymerize or polymerization, you need to think about getting insoluble. Okay? So in other words, it went from that liquid to a milkshake. All right? We took ice cream, put it in milk. Milk was liquid. We added ice cream to it, made it thick. Right? Okay? That's what happens with hemoglobin S. It polymerizes. When polymerization occurs, you're basically going to get thick. You're getting connections that occur. Okay? You're going to get bonds that usually aren't there. Okay? And all it is because of the low oxygen level. Okay? So what happens is, all that hemoglobin that's inside that red cell, okay? So that's your red cell, and this is the hemoglobin that's in it. Okay? Normally it's a liquid like it's supposed to be all the time. Okay? But then as soon as the oxygen level changes, it changes. Okay? So now it gets thick. It like becomes cross-linked like this. And so now, instead of it being flowing like a liquid, now it kind of gets cross-linked and it becomes thick. And so what happens, the membrane, the hemoglobin attaches to the membrane and then it sucks it down together. It pulls the membrane closer to the center because it's doing basically little cross bridges. If you were looking at the atoms, they're all crossing and bonding together to form little bonds in between the molecules. Does that make sense? Okay? All right? But listen to me closely. At this point, it's like a milkshake. Okay? Still thick, but it will still flow. Does that make sense to you? Okay, that's important because we're going to talk about hemoglobin C in just a minute. And hemoglobin C don't move anymore. It actually crystallizes. Okay? We're going to talk about that in just a minute when we start talking about hemoglobin C. Okay? But right now, know that it's liquid. As soon as oxygen level drops, it polymerizes. So it turns thick like a milkshake. Okay? As you go. Alright? Questions about that? That makes sense? Okay? So then you get that crescent shape that we see as typical sickle cell. Okay? Alright? So, here's what's really cool. Okay? Hemoglobin S polymerization is actually reversible. Okay? If you can get a patient who has sickle cell anemia, which is the disorder, okay, when their oxygen level drops, their cells are going to sickle naturally, because that's what happens. You can actually create it in a lab. You can take a person who has sickle cell anemia, put their blood under the microscope, under a microscope slide, put a drop of blood on it, and then cover slip it and seal the cover slip with like nail polish or something so that air can't get under there. Eventually what will happen, the oxygen level will drop in that sample and the cells will begin to sickle naturally, okay? And there's actually a test, we'll talk about it. You can add a chemical to it and do that exact same thing to screen if a person is actually has sickle cell, okay? But what's cool is, if you come to the ER quick enough, within about 4 hours, okay, you can actually reverse sickle cell, okay, all right? But it depends on how long. You have to do it quickly. If you don't do it quickly, and those cells remain polymerized for a long period of time, they become what's called irreversible sickle cells, okay? Irreversible sickle cells, okay? So it is time dependent, very important, okay? So deoxygenation. So places that are hypoxic, acidosis, okay, y'all know what acidosis means? Have I used this term with you guys yet? Okay, so we have acidosis and alkalosis. So remember the other day we talked about a little bit, a long time ago, I guess, at this point. We talked about our blood pH. Oops, I can't spell blood. Blood pH, I told you guys 7.35 to 7.45. That's what we want our blood pH to be, okay? That's the minimum, that's the best place for like enzymes and those kind of things to work properly, okay? So that's where we want our blood to be, all right? If my blood goes lower than this, okay, anything lower than 7.3, this is known as acidosis, okay? If it goes above the 7.45, this is known as alkalosis. All right, we got a whole chapter in clinical chemistry that deals with acid-base balance and the pH and stuff.
Wouldn't you die either way though?
Yeah, you die either way. Yeah, you can die either way, depending on how low it gets or how high it gets. Yes. Okay. It's the reason I'm not like a big fan of these alkaline waters and all that kind of crap. I'm not a big fan of that stuff because we have good buffering systems in our body, but if you drink water all the time and it's that alkaline water, eventually it can lead to alkalosis and you can die from it. I mean, people just don't know, you know. I hear all this stuff all the time. Oh, cancer cells can't live in alkaline environments, and so if you make your blood alkaline, you won't get cancer. Yeah, you won't get cancer because you'll be dead. You know, if it gets too high. Okay. So acidosis. So acidosis, I talked about low when oxygen happens, or when acidosis occurs, oxygen level drops. Okay. So remember the other day we were talking about hemoglobin, and we put this on board, and then we talked about that there was a right and a left shift of the hemoglobin oxygen dissociation curve. Remember I was talking about that in the last chapter, or in chapter 6 with hemoglobin. We'll talk about hemoglobin, okay? So remember, pH decrease was one of them, and pH increase. It shifts it to the right or to the left, and so therefore we don't hold on to oxygen, or our affinity and avidity changes, okay? So that's what we're talking about. So if you get in a hypoxic situation, of course, you don't have oxygen. That's what the whole problem is. But in acidosis, it affects it also, because your tissue starts sucking in oxygen more than what it should. So the oxygen level in the red cells can actually drop, okay? Hypertonicity, so something that gets off your osmotic balance, your equilibrium, those kind of things. And then temperature is greater than 37 degrees. So people who have sickle cell anemia, they get a bacterial infection in their body, their fever goes up, they can go into what we call sickle cell crisis. And we'll talk about that in just a minute, okay? All right, so all these are things that cause polymerization of hemoglobin S, okay? So be aware of those, all right? Here's the problem. We have lots of places in our body that have these environments, okay? One of the big ones, guess what? Bone marrow. Where those cells are forming to start with is a very hypoxic, acidotic area of our body. Guess where another place is? The spleen, okay? So the areas where extravascular hemolysis occurs are areas that cause cells to sickle, that have people who have sickle cell anemia, okay? So if I'm busting cells in those areas because they're not normal, what's going to happen in my blood marrow, my bone marrow? What's it going to do? If I'm losing blood, what does my bone marrow do?
Make one.
Makes more. So it initiates erythropoiesis, right? So plasia, you remember that term? So what would my bone marrow be? Hyperplasia, that's right. It'd be hyperplasia, right? So that's one of the signs you'll see, okay? So what about reticulocyte count in patients that have sickle cell anemia? Increase. Why? You didn't know why. You just told me. Why?
Because you increased erythropoiesis, which means that you increase.
There you go. That's exactly right. It's good because if you ever increase erythropoiesis, what are you also going to increase? Your reticulocyte count. It's automatic. It has to be, right? Okay. So patients that have sickle cell anemia, they have hyperplasia bone marrow, and they also have increased reticulocyte counts. Okay. So that's one of the things you can see. All right. So here's something that's cool though. All right. Remember the other day I told you guys that the amount of hemoglobin in each cell may not necessarily be equal every time. Does that make sense?
Can you repeat that? Sorry.
So the other day we were talking about, we said that a red cell, a normal person red cell, should have like 95 to 97% hemoglobin A, right? And then we said, you know, it should be like 0 to 2% hemoglobin F. And then, what was it, like 1 to 2% hemoglobin A2, right? But I also told you that every cell may not have exactly that amount in it. It may be 93 and a little bit more hemoglobin F, a little bit more A2. It just depends on what's going on, right? Okay, remember we talking about that? Same way with people that have sickle cell. Sickle cell patients, they're not ever going to make A, okay? Ever, right? But they are going to make hemoglobin S. But what happens is sometimes hemoglobin F gets increased in these patients because hemoglobin S doesn't have the same avidity and affinity for oxygen as hemoglobin A does, okay? So what happens is our body compensates. If it says, I'm not getting enough oxygen, it'll upregulate production of hemoglobin F, okay? So the more hemoglobin F that is there, the less polymerization occurs when the oxygen level gets low. Does that make sense?
So less
Okay.
polymerization?
That's it. And what's happening is because the hemoglobin F, okay, so let's say, this particular cell, the white represents hemoglobin F, and the red is S, okay? Because there's more of that hemoglobin F than what is normally there, it blocks those bonds. The chemistry does, okay? Because it still has those same amino acids that have polar and nonpolar also, and so therefore it blocks polymerization. And so you don't have as much of the milkshake. You get more of the liquid. Does that make sense? So it's like, I like my milkshake. I don't like a milkshake that's, I gotta suck my brain out and suck it up the straw. You know what I mean? I like for my milkshake to be a little thin. It's still thick like a milkshake, but it's thin enough for me to drink it up with a straw and not kill myself. You know what I mean? I want my brain leaking out my ears because of, you know, that kind of thing. Does that make sense? And so that's what's happening here. This is my milkshake. The hemoglobin F makes it thinner because it does what it's supposed to do. So it can't get quite as thick. And so like, this one may only have like, you know, if it's got an increase in F, it may only have like 70% to 80% of the hemoglobin S. And so you're getting that increase in F and A2 to compensate. Does that make sense to you guys? Okay? So that's really important to understand, that not every cell is going to have exactly the same amount of hemoglobin S in them, okay, as you go. All right? So total hemoglobin concentration at MCHC. Okay, we talked about MCHC, right? It's one that we look at for hypochromia, normochromic, or spherocyte, hyperchromic, okay? Increased in MCHC in people who have hemoglobin S leads to more polymerization. In other words, that patient has more of a chance of forming sickle cells than a patient that has a low MCHC, okay? So in the case of sickle cell anemia, if the patient has low MCHC, that's a good thing for them. Does that make sense? Because they're less likely to polymerize and turn into the milkshake when the oxygen levels get low. Okay? Questions about that, guys? All right. So polymerization of deoxyhemoglobin S, so this is talking about hemoglobin S without the oxygen, it gets at about 85%. Okay? So I don't have sickle cell, but when I was, to give you an idea, when I was sick with COVID back in December or November of 2020, my oxygen was 65 when I went to the ER that morning. My oxygen saturation had dropped to, I take that back. It had not dropped to 65 when I went to the ER. It was like 85 at the ER. But I went in the hospital on Tuesday. By Thursday, I had dropped to like 65. And not only had I become 65 oxygen level, I had also become acidotic. In other words, I was in acidosis. My blood pH was dropping. You know, I was down to like 7.2. Okay? So it's a wonder I even survived. So what did they do? They put me on oxygen. So if I would have been a patient who was a sickle cell patient, I would have been in what's called a sickle cell crisis. Okay? That is important to know. Okay? That word is important to know. Sickle cell crisis. That's a S, not a 5. Crisis. Okay? Sickle cell crisis. All right. So, let's talk a minute. We're going to have a practical tomorrow. Okay? I have a lab practical tomorrow. Everybody hear me? Let your buddies know they're not here. I don't really care, but you can let them know if you want to. If not, you can be, hey, I'm going to make 100 and you ain't because you didn't study. I don't really care. Okay? Have lab practical tomorrow. So one of the slides on the lab practical has sickle cells on it. Okay? One of the things I'm going to ask you is, what is the diagnosis of this patient? Okay? The answer is not sickle cell anemia. Okay? Yes, they have sickle cell anemia, but what did I just tell you about patients that have sickle cell anemia?
It's a symptom of a disorder.
No. What did I tell you about people who have sickle cell anemia? Who are just walking around, everything's normal, no problem. What's their cells look like? They look like mine and yours. They may be a little washed out, a little hyperchromic, but as far as cells, they look like round red blood cells, like they're supposed to. But then when the oxygen level drops, then what happens to the cells? They sickle. And when they sickle, that patient's in a crisis. Okay? So anytime you see true sickle cells, now listen to me. Even on a normal sickle cell person, you may see cells that look like this. Okay? Alright? Or usually they're more rounded like that. More like this. They look like a boat. Or like the bottom of a boat. Okay? These are those IRS. Okay? Irreversible sickle cells. Okay? That's what we were talking about earlier. Remember I told you if you can get the oxygen to them, they'll revert back, but if it takes too long, they won't revert back. Well, they'll try to, but they won't get but about that far instead of getting that good biconcave shape, okay? This is a sickle cell. That's a true sickle cell, okay? That's what we call sickle cells, all right? So if you start seeing these on a slide, then you know your patient's in a crisis, okay? And that's very important because if you put sickle cell anemia, guess what? I'm marking it wrong because I've told you, right? Okay. So sickle cell crisis is when we actually start seeing them. And most time, listen, guys, you're going to look it up when you start working in the lab, you're going to have the patient's diagnosis. And what they're going to have on the diagnosis is sickle cell crisis. They're not going to have sickle cell anemia, okay? They're going to have sickle cell crisis because something has happened to make their cells basically drop, or their oxygen level drop below 85, okay? All right? So, repeat cycles. In other words, if you come in with low oxygen level, we get you fixed back, and then you go home and, you know, you're doing whatever to get your oxygen level dropped again, it can start causing other problems, okay? Repeat cycles of sickle cell. You get disruption of the cation homeostasis. Remember, the 3 cations that we need to always be concerned with are potassium, sodium, and calcium. Okay? Those 3 cations are very, very important to us in our body. Okay? Calcium plays a role in lots of different things. But one of the main roles it plays in is clotting, muscle contractions. Okay? Those are the 2 big ones that we worry about. It plays other roles too, but those are the 2 big ones for us. Okay? Because if our muscles aren't contracting, guess what? Our heart ain't working. Right? Also, if we're having blood clots and we're having infections and those kind of things, we can be prone to blood clots. Okay? Pulmonary embolus. Okay? Those kind of things. Those kill us. All right? So we need our calcium working properly to make sure that we're flowing like we're supposed to and not clotting off. Okay? All right? So, loss of potassium in the cell. Okay? And water from the cell. So basically you have what's called you end up with like a hypotonic environment inside the cell. Okay? So, if you lose potassium in the cell, okay, so y'all remember that the other day? We talked about this the other day. So, inside the cell, right, what do I have more of? Sodium or potassium? Potassium. I have more potassium inside the cell. Okay? All right, so for instance, serum, plasma, whatever, doesn't matter, 135 to 145 millimoles is what most time they use. Millimoles per liter, I believe, is one. There's also what's called milliequivalents per liter is your normal range. This is sodium, okay, in the serum. Serum potassium level is like 3.5 to 5 millimoles, okay, per liter, okay? That's in your serum, all right? Inside the cell, they're almost reversed, almost completely reversed, okay? It's a little bit off, but almost opposites of each other, okay? So, if this is my normal level in my serum, right, and this is the normal for potassium, when this goes up, because what's happening to these potassium ions? They're coming out of the cell, so what's it going to do to this level? It's going to raise it. You know what happens when our serum potassium gets high? Very simple. We die. Yeah. We just die. Okay? Because what will happen is, this goes up, what's going to happen to the sodium level in here? It's going to increase. Okay? So then not only do we have high potassium, but what happens to our sodium level? It bottoms. You know what happens when our sodium level bottoms? We die. Yeah. Okay? Because we like for things to be equal with each other. And so when you start getting that unbalance, bad things start happening to you. Okay? So not only do these patients have to worry about not getting enough oxygen, but they also have to worry about those electrolytes. Okay? So basically it's like a train wreck when a person comes in with sickle cell crisis. Okay? Alright? Increase in cytoplasmic viscosity. Okay? Why would that be a problem? Cytoplasmic viscosity. What does viscosity mean?
That's what I would say.
Like how thick it is, like oil. Oil's viscous, water's not, right? So if you have an increase in the viscosity inside a cell, the cytoplasms of the cell, we need things to go in and out of the cell, right? And if they're not going in and out, we have lots of problems, okay? Because things get so bad. So then you have decreased cell deformity, okay? All right? That's going to lead to something in just a second we're going to talk about. So hold note on that right there, okay? All right, so we talked about irreversible sickle cells, ICSs. I put an IRS, but it's ISCs. It doesn't matter. It's about the same thing as long as you know it's irreversible sickle cells. These occur after repeat cycles. So basically what happens, they become locked in that sickle shape. In other words, what basically is happening, that polymerization can't reverse. So in other words, instead of it going back to the liquid, you're stuck with a milkshake, okay, as you go. And so therefore it messes up the shape of the cells. So ovoid or boat-shaped with a smooth outline is usually what you're going to see. Low MCV, high MCHC on these patients, okay? They're usually removed by the mononuclear phagocytotes in the spleen. So basically I don't know why they had to be so fancy. Macrophages is essentially what that is, okay? Sickle cells seen on blood smear in people that have that reverse. That's what we were talking about. Those are those irreversible sickle cells. Initiate increase of the severity of the vaso-occlusive crisis, okay? Here's what we're going to talk about in just a second. This is important. Vaso-occlusive crisis. Okay? And the reason it is because of the impaired deformability of the cells. Okay? So let's go ahead and talk about that real quick. There's another slide for this, but let's just go ahead and talk about it because we've mentioned it twice. Doesn't really matter as long as we get it mentioned. Okay? Everybody have a good weekend? Huh? Caught up on sleep. I didn't know that was a such thing. All right. Let's get some clean canvas here. All right. So, blood vessels. So, we got capillaries. All right. So, we know we talked about capillaries is where gas exchange occurs. Okay. Here's the problem. Capillaries are very small. All right. So, if you think about it, the venules and the arterioles, they're really large. So you can have blood kind of all through it all the time. And it's kind of going through in masses, okay? But what happens is, eventually, it's going to get constricted down to single cells passing through capillaries, okay? In our body, our capillaries, guess what? This is the lumen. They're shaped round like they're supposed to be. Things are supposed to just shoot through like they're supposed to, okay? Remember, sometimes we talked about that the capillaries are so small that sometimes the red cells are larger than the capillaries, right? Because remember how we talked about that was important, that they have deformability, that they can form down and go through and then pop back up. When we were talking about red cells, okay? So sometimes the capillaries are even smaller, okay? So as long as the cells are round, they kind of stack up like coins and go through like they're supposed to. and gas exchange occurs like it's supposed to, and everything is good to go, right? Okay? But then you're a sickle cell patient and you get pneumonia, all right? Get pneumonia, your lungs are full of bacteria and white cells, pus, and everything else that goes along with pneumonia. Guess what happens to your oxygen level? O2 drops. Let's say your O2 is 75%. What's going to happen to these red cells? They're going to sickle. And they start way the crap over here. Okay? And as long as they're over here, they got plenty of room to do what they need to do. But as soon as they end up in here, they're this shape. So what's going to happen? They're going to get stuck. And it's going to clog up. Okay? So, back here, everything's fine. Tissue's good, it's still getting blood, blood flow's good, still getting oxygen. But everything this direction, what? No oxygen. So oxygen level's dropping even lower. Okay? So this one stacks, and then you start getting build up here of blood because our blood's got to continue flowing no matter what. So what happens to here?
The pressure increases.
Pressure increases, and then what eventually happens?
Explodes.
It explodes. It bursts. So you get strokes. People get strokes from this. Aneurysms. Okay. Pain from not getting oxygen like they're supposed to. Tissue becomes necrotic. You know the term necrotic, necrosis. Okay. Those kind of things happen. That's the reason people who have sickle cell anemia have pneumonia lots of times. They're prone to bacterial infections. They're prone to have their legs amputated. Those kind of things because of gangrene. Okay? What causes gas gangrene? What is the agent that causes gas gangrene? Okay, guys, this is basic micro. You got to know this. It's very, very important to know. It's a group of organisms that have the worst toxins in the world. Which group of bacteria has the most toxic toxins that we know in mankind? 3 of them. It's actually 4, but one of them got its name changed recently. Drawing a blank. You haven't paid attention in Miss Cole's class, did you? Okay? Clostridium. The genus Clostridium. Clostridium perfringens is the organism that causes gas gangrene. Get that double zone hemolysis. Okay? It's an anaerobic bacteria. Gram-positive rod. Right? Clostridium botulinum causes botulism. Right? And then the other one is Clostridium tetani that causes tetanus. Those 3 organisms, same genus Clostridium, produce some of the worst toxins in the world. Okay? Very, very bad toxins. Okay? Those 3. The people who have sickle cell can end up getting gas gangrene in their legs, arms, hands, those kind of things because of circulation. They don't have circulation. So a lot of times they may have to have amputations. Okay? Another thing that sickle cell does because of crisis or these occlusions is it can lead to kidney disease. Okay? A lot of patients that have sickle cell anemia end up on dialysis because of this, because of vaso-occlusion problems. Okay? Questions about that, guys?
With the sickle cell, does it still have a lifespan of 100?
No, it doesn't. That's one of the things we're going to talk about. That's sickle cell, especially like the irreversible sickle cells. They don't have a lifespan. Some of them like less than like 18 days, 14 days. Okay, so that's another thing that causes problems. If you have a patient that their red cells are dying every 18 days, what's their haptoglobin level going to be?
Very high.
Very low, because they're going to lyse those cells more often. Therefore, it's going to happen intravascular and extravascular. So they're going to end up having, and we're going to talk about this in just a minute, a lot of patients who have sickle cell anemia do what's called an autosplenectomy. Okay? What's auto mean? Self. Auto always means self. Okay? Autosplenectomy. So basically you destroy your own spleen in your body. It's there, doesn't nobody remove it, but it don't work anymore. That's a very common symptom of patients that have sickle cell. Because basically what's happening, every time a sickle cell goes through the spleen, what's that macrophage going to do? It's going to eat it, right? And eventually it basically just overworks it. And you just can't do anything about it. Same way with the liver. A lot of times the liver, they get liver disease too, because the liver's trying to break down the hemoglobin all the time. That bilirubin, biliverdin, all those things we talked about with hemoglobin breakdown. Okay? All those different things happen as we go. Okay? All right? Questions about any of that, guys? All right, I mentioned this a little while ago, but let's mention it again. Basically, your oxygen affinity is different in people who have hemoglobin S. The affinity is actually decreased, okay? So if it's decreased, that's the reason why we're getting that increase in hemoglobin F and A2, is because their affinity for oxygen is a lot better, okay? So if our affinity is low for O2, what's our avidity? Is it low too? Yeah, most of the time it is. Most of the time you see that. But the problem with these patients, though, is this right here. Remember 2,3-BPG? We talked about it when we was talking about the dissociation curve of hemoglobin. So what happens, we get a shift to the right. Okay? Remember I had that up there just now? Let's do white. Had it up there a while ago. And we said this is normal. We got that sigmoid curve. But then you get that shift to the right. Okay? So in this case, look. Our affinity increases, and so does our avidity. All right? If that's happening, is that a good thing or a bad thing? It's not a good thing, because what's happening to our tissues? The hemoglobin's grabbing oxygen like it's supposed to. It's actually grabbing it really, really good. But what's it also doing? It's not relaxing to let it go, right? It's staying in that tense state. Remember we talked about the tense and the relaxed state of hemoglobin? So it's staying in that tense state, so it's not ever releasing the oxygen, okay? So even though it may be there, it's not turning it loose to the tissue. And so the tissue becomes necrotic from this, okay? Question about that, guys? All right. So, RBC destruction of hemoglobin S, it is extravascular hemolysis, just like we talked about before. The increased fragility of the RBC membrane leads to Heinz body formations, okay? And then it decreases the lifespan. Some of the sickle cells can actually have a lifespan of like 14 days. So you're going to have that huge turnover of red cells. So therefore, that's what leads to that hyperplasia of your bone marrow. Okay? All right, questions about that?
What's the plasia?
Plasia means an increase in production. So if we got hyperplasia, means we're getting overloaded in our bone marrow. And that can lead to a problem. And we're going to talk about that in just a second. Okay? So one of the things that hemoglobin S polymerization occurs, it does cause a sickling, but it also causes sluggish blood flow, which leads to hypoglycemic and hypoxic environments of the spleen. Circulation slows in the spleen. Okay? So if you've got slow moving cells, those macrophages can see the cells more better. Okay? So in other words, when they're coming through really, really fast, they may not be able to grab every one of them. But if they're moving slow, they can grab them all. Okay? Anything that's abnormal. And so what happens, basically it overworks your spleen. Okay? So spleen loses its function, functional capacity with repeated ischemic crisis. What's ischemic mean? Y'all seen that term? Ischemic? Ischemic means low blood flow, is what that term means. Okay? Low blood flow. And then it leads to splenic necrosis or atrophy. And atrophy means decrease in size. So basically it dies. Okay? So, when do we first see clinical signs of sickle cell? About 6 months. 6 months of age, we start seeing that. Normally, a 6-month-old should have an increase in which hemoglobin? A or F?
Or is it over a year?
It's F. It's a year. Over a year old. Once they reach a year old, I mean, they're producing A, don't get me wrong. But they're still producing a lot of F, a lot of fetal hemoglobin at 6 months of age. So what you see is you see a decrease in hemoglobin F, okay? So hemoglobin S predominates over hemoglobin F. And so you start seeing more crisis activities in the babies also, okay? So you see chronic hemolytic anemia in these patients. You see vaso-occlusion, overwhelming infections. This is usually what kills people who have sickle cell anemia. It's usually not the sickle cell. It's usually not the anemia or anything like that. It's usually they die from some infection. Usually encapsulated bacteria. So things like Klebsiella pneumoniae, Streptococcus pneumoniae. Those two are big organisms that have a capsule. Okay. You guys talked about Cryptococcus yet? Cryptococcus neoformans. It's a fungus. It's a fungi. Yeast. It's a yeast. Y'all ain't got there yet? Y'all will. Y'all get there pretty soon. But anyway, sometimes patients with sickle cell can have problems with Cryptococcus also. But the two big ones that I want you to know are Klebsiella pneumoniae and Streptococcus pneumoniae. And those are the two big ones that you're going to see cause this. Okay. Other things with the anemia, they can have folate deficiency, which leads to some larger cells being produced. Okay. Bone marrow, we talked about that already. Hyperplastic changes. When you have hyperplastic bone marrow, it also affects those osteoclasts and osteoblasts. Okay. Because basically what happens, you remember, remember how we talked about the bone marrow is usually in the long ends of the bones, the long bones. So they're kind of shaped like that. And we talked about how you've got those trabeculae and all of those net kind of fibrous opening spots. And then you got bone marrow kind of growing in between all this stuff. All these holes that's in there. Okay? And that's about all you got. That's about all the bone marrow you got is in those bones. Okay? But when you have hyperplasia, what happens? You get increases in the bone marrow. Okay? So if you get increases in the bone marrow, what's it going to do to the bone structure? It's going to thin it out. That's exactly what happens. It starts busting up this bone that's in here. And so what you get a lot of times is this weird hair-like projections that come off. When you look at it under x-ray, you start seeing this weird hair-like, called hair on end appearance of the skull. See that? Looks like a person's got hair on the x-ray. See all that stuff up here? That's not normal. Looks like fuzzy skull. It's a fuzzy skull. Okay? This is a sign that they have really, really bad anemia, and you have that hyperplasia on this. You also see this in thalassemia, too. We'll talk about that in just a minute. Okay? Eventually, what happens is you get what's called an aplastic crisis. Okay? Usually, it follows a viral. Okay? So, hyperplasia, okay, means an increase. What would aplastic mean? or aplasia mean? If I put A in front of a word, what does that mean? It means none. It stops. No. So in other words, our bone marrow quits working. And it's known as aplastic anemia at this point. Okay? So they get what's called an aplastic crisis. What happened? Essentially, they wore out their bone marrow. Okay? They used up all their stem cell pool, their HSCs. Okay? Because of this. Usually it's after viral infections, bacterial, mycoplasma. Y'all talk about mycoplasma pneumonia? Okay. Those types of infections. Of course, it leads to worse anemias, lasts a few days to a week, and then can induce severe decrease in hemoglobin concentration. And eventually they can die. Okay. Vaso-occlusion, we talked about that already, so we can skip that. There's your little picture of those so you can see what's going on in vaso-occlusion. Okay. Other things about that. Splenomegaly early in childhood, that usually is a good indicator something's going on. Okay. Dactylitis, I don't know if y'all have ever seen that term before. This is joint pain. It's like people have arthritis and these kind of things, but it leads to this because of the vaso-occlusion. Their tissues not getting the oxygen that it needs. Usually in the hands and feet, have swelling, those kind of things. Thrombosis, of course, are blood clots, strokes, blindness. That's a big thing too. I didn't mention that already. People who have sickle cell end up with blindness a lot of times because the little vessels in the eyes get that vaso-occlusion and it leads to blindness. Okay. Here's bacterial infections. This is what we're talking about before. This is usually what kills them. Luckily today we've got lots of vaccines for like pneumococcal vaccines. So that's something that, a lot of people will take now, especially older people. And it's basically to fight against Streptococcus pneumoniae, okay, as you go, okay. Trying to see if there's anything else. This is kind of unique, acute splenic sequestration. So remember we talking about how the blood flows through the spleen and sometimes it slows down so it's able to grab more of the red cells. So what happens is the spleen actually starts basically pulling so many cells out that they have such a blood loss that they can die from blood loss, okay? Which is what hypovolemia means. Hypovolemia is a low blood flow, okay? And so that's one of the things that happens. It's called sequestration crisis. And you see this sometimes in children, especially. Adults, it's usually not a problem because we have enough blood volume, but little kids don't. And so with the spleen pulling tons of those red cells out of circulation, it actually can cause a drop in hematocrit, like way drop, So it causes problems for these patients. Okay? Questions about that? Acute chest syndrome, most common cause of death in children who have sickle cell. And it's essentially, it looks like a pneumonia, but it's essentially their chest is kind of collapsing. Their lungs are collapsing due to unoxygen, hypoxia, and all that kind of stuff that is occurring. Okay, so be aware of acute chest syndrome is usually the most common cause of death in children who have sickle cell. Okay, sickle cell anemia can actually lead to iron overload. So this is one of the things you have to be concerned with. They get iron overload because of the frequent transfusions that they have to have. And so their body loses that ability to remember only need so much iron. Because remember, they're doing hyperplasia. So those red blood cells are dividing really, really quickly. So their body thinks, hey, I need to take in more iron. And so they do that, and then it leads to iron overload. Okay? So be aware of that. CBC, it's unique because it's a normocytic normochromic anemia. It's not like iron deficiency that's microcytic hypochromic. These are actually normocytic normochromic anemia. Huge increase in retics, low hemoglobin, low hematocrit. You can see an increase in white cells and platelet counts. Usually the white cells just because it's a weird stuff going on and it causes your white count to go up. Okay. Variable initiocytosis on the smear and variable poiculo depending on what's going on. Of course, you're going to see polychromasia increase because they have a high retic count. Remember, the polychromatophilic cells are usually reticulocytes, okay? And the big one that you see, poikilocytosis of the poikilocytes, sickle cells, target cells. What's sickle cells called? It's their science name. Drepanocyte. Make sure you know that. Drepanocyte. D-R-E-P-A-N. Oocyte. O-C-Y-T-E. Okay? Drepanocyte. Okay? Target cells are called what?
Starts with a C.
Yep. Codocyte. There you go. Boy. Codocyte. Also see increase in RBCs, or C in RBCs. You can't really say increase. You see in RBCs because they should never be there. You're also going to see a increase in RDW. And then there are other things that you see that are weird because the spleen's not working properly. So you'll start seeing basophilic stippling, Hal-Jolly bodies, and also siderocytes. So you're going to see like Pappenheimer bodies, okay, as you go. Okay? Questions about that? And this is what your typical blood smear will look like on a patient that has sickle cell anemia. All right, questions? How are we doing time-wise, guys? Huh? About 11:30? Okay, give me about 15 more minutes. Can I have 15? I actually can have 20 if I want it, technically, okay? But if you give me about 15, I think we can get it. So we've already talked about bone marrow, so we're good there. Electrophoresis, we talked a little bit about it. Cellulose acetate at 8.4, you're going to have about 80 to 95%, so your hemoglobin S band is going to be really large. It's not going to be as large as like the hemoglobin A in a normal person would be, though, okay? And the reason you don't have that is because you have that compensation, because our cells, hemoglobin S doesn't have a high enough affinity for oxygen, so we increase our hemoglobin F. And A2 sometimes too. Most of the time it is normal, but sometimes you might see an increase. So hemoglobin F levels can actually be between 25 and 35% if need be, okay? So 5 to 20% though is what we typically see, okay? So 60 to 80% in newborns of hemoglobin F, and then the remainder of hemoglobin S for them on the electrophoresis. All right, let's talk about solubility test. So solubility test is a really neat test. How many of you guys got your book? Let's see. Let me see if I can find it real quick. Look at there, turn right to it. Page 799, chapter 37. Okay? You guys can't see it. If you don't have your book, I'll hold the picture up for you guys. So you see this picture right here? Okay. So this is a solubility test. So essentially what you do is you add a chemical that should kind of hemolyze the cells. And what it does, it basically creates a hypoxic environment. Does that make sense? When you add the chemical creates basically an acidic hypoxic environment. So if we put the cells in a hypoxic environment, what should they do? What should cells that have hemoglobin S in them do? They should sickle. So if they become sickle cells, what are they going to do? They're going to become polymerized. And so they become thick, like the milkshake. Okay? People who don't, it just hemolyzes the hemoglobin, and that's what happens. It pops the red cells, and they release the hemoglobin into the solution. Okay? So then you hold it up against a background, and you look for the black lines. If it's normal, you can see the lines because the hemoglobin A just, it stays liquid and there's no problem. But if you can't see the lines, then you got a solubility problem, okay? Does it mean this is diagnostic for hemoglobin S? No, it does not. This is a screening test. What would be my next step? Hemoglobin electrophoresis. And here's why, guys. People who have hemoglobin S trait will also have a positive solubility test, okay? So it doesn't matter if you have it or not. If you have the trait even, this will be positive. And then we would do our electrophoresis and determine if it's true hemoglobin S or hemoglobin S trait. That makes sense? And some of the other variable hemoglobins, like the hemoglobin E, hemoglobin C may actually do this too. I can't remember right off the top of my head. But I know there's some other hemoglobins that will be positive in the solubility test. Okay? All right? This one's done a lot in labs. You may see this sometime in your lab. And listen, if you live in a population or a hospital that has a huge African American population, you're probably going to do more than these if you lived in a place that didn't have a lot of African Americans. Okay? Does that make sense? And that's why, because of the population. Okay? Because it is a good screening tool to get some information. And a lot of times they'll do these on babies. You'll see like a bunch of little finger stick tubes come in, and they'll do them for that. Okay? All right. So it's that solubility test. Sickling test. This is the one I was talking about. It's called a metabisulfite slide test. This is the one I was talking about earlier, where you put blood under the slide, seal the slide with a cover slip, and then just let it wait for a little while. And the oxygen basically comes out of the cells, and they will sickle if it's positive. Then you just look at it under the scope without any stain, so you'll be able to see the red cells, but they'll be sickled, just like they would if you were staining. And then, of course, these other diagnostic tests. These are electrophoresis types, okay? These are, one of them is a chromatography, which is essentially the same thing. And then, of course, DNA testing. You can always do DNA testing and check for that mutated gene on the beta chain. Okay? All right? Other things you can look at, we're not even really going to talk about that, but you can look at those tests also. All right? Questions. Therapy. Okay? Best therapy is supportive care for like dehydration, making sure that they have oxygen, prevent infection, transfusion. And then the big one today, if you guys have been paying attention in the last 5 or 6 years in the news, what are we doing? Stem cell and gene therapy. We cured a sickle cell person in Mobile, Alabama, and one in Chicago. I think it was a female in Chicago and a male in Mobile. Okay? They have been cured from sickle cell. All right? All they did basically is they went in and replaced that mutation in that gene and made it produce hemoglobin A instead of S. Okay? Took out that one codon, essentially, and fixed it. Put it in for glutamic acid instead of valine. And it was able to cure them. Those two people are cured. I don't know where it's at now, like the research and that kind of stuff, or how prevalent the use of it is, but we did prove that we could do it with those two patients. Okay? Questions? All right. So sickle cell trait, just be familiar with it. Know what the trait is. It looks like this. It's usually not severe anemia. They may have a little mild anemia, but it's usually not any problems. And you don't normally see sickle cells. Even if their oxygen load gets low, you don't see it that often. But if it got down to like mine, 65, yeah, they probably will sickle a little bit. But it won't be as prevalent as a person who has true sickle cell. Okay? Questions? Okay? It's important of the diagnosis, make sure both parents have sickle cell trait. Then you've got that 1 in 4. I am not putting a Punnett square up there, but you guys know if you get two heterozygous together, you have a 25% chance of getting the disease. Y'all remember that from Punnett squares in biology? Okay, good. Okay. So normal CBC, no anemia or sickle cells. The sodium metabisulfite would be positive, and so would the solubility test on these patients. Because essentially why the slide test is positive is because you're sucking so much oxygen out, it will cause those cells to sickle. Okay? But most people, like normally just walking around, are not going to have that low of oxygen because you couldn't walk around. You'd be dead. Okay? Or almost dead. All right? So that's why the trait doesn't have as much problem. Okay? So notice on the electrophoresis, you are going to have hemoglobin A, and you're actually going to have a bigger band of A than you will the S. Okay? But the S will be present, and that's one of the things you need to make sure you can identify. Okay? Question? Okay? There are some other sickle cell things that can be in combination, and we'll talk about that later on, but you can have a patient have sickle cell and thalassemia, okay? Those people, of course, are going to be more prone to have more severe anemias than somebody else, okay? All right? Questions about sickle cell trait? All right. We're going to stop right there. We'll finish up. Today's Monday, so we'll finish up Wednesday with this, all the hemoglobinopathies, and we will start thalassemias Wednesday, okay? Because we're going to go through hemoglobin C and SC really, really quick, and then we'll start thalassemias and go through them pretty quick, okay? So on the schedule, I've got March the 23rd for our test, right? Okay? And everybody told me you had a laptop, right? Everybody's got a laptop, correct? Anybody don't have a laptop? Okay. So push comes shove, we may just take our test in here, if y'all are okay with that. Okay? All right. All right. So lab practicum tomorrow. This will be lab practicum. Huh? Excuse me?
Over what?
Over everything we've done in the lab so far, and over this stuff. Okay?
So it's gotta be from IDA.
From the beginning of lab to today. So it's all free game. Okay? So if I put a lymphocyte up there, you better know what a lymphocyte is. If I put a reactive lymphocyte, you better know what a reactive lymphocyte is, because you've seen all that stuff, right? Okay? If I put sickle cell up there, you better know what sickle cells are. You better know it's sickle cell crisis. Okay? If I put a electrophoresis up there, you better know electrophoresis.
Anything from a dip to a red cell morphology.
Yep. Anything. It's my prerogative. It won't be anything you ain't seen. If something's on there that you haven't seen, I'll give you the answer to it. And then you're responsible for it. If I show it to you and tell you the answer. Does that make sense? All right. I think there's like 20. I think there's like 20 of them. So